And it's really my pleasure to introduce Dr. Robert Rodriguez. So I want to say just a couple of words about how we connected. So some of you might know that we have a new initiative within CIMH called the Research Highlights. And so our goal here is really to bring research to practitioners. And one of the highlights that we started off with was Dr. Rodriguez's work looking at how Latinx immigrants are impacted by the political rhetoric in terms of their feeling of safety in accessing healthcare. So Dana, Rush, and I had come across the article and decided to incorporate it as one of our first research highlights. And through that, we connected with Dr. Rodriguez, who was very kind in offering to come to CIMH and present to the group. And so we're really looking forward to his talk. Let me just briefly read a little bit more about him through his bio. Dr. Robert Rodriguez is a professor of emergency medicine and the Associate Chair of Research in the Department of Emergency Medicine at the UCSF, University of California, San Francisco, School of Medicine. After the University of Notre Dame and Harvard Medical School, he completed a combined emergency medicine, internal medicine residency at UCLA and a critical care medicine fellowship at Stanford. He is a former Department of Emergency Medicine Diversity Director and a recipient of the UCSF Martin Luther King Jr. Award. Recognizing the pivotal role that emergency departments play as the safety net of the safety net, much of Dr. Rodriguez's research centers on emergency health centers, healthcare access for underserved populations, especially immigrants, homeless persons, and communities of colors. With multiple grants, including an R01 from NIAID, Dr. Rodriguez has led national research teams examining the effects of the pandemic on the mental health of frontline providers, vaccine hesitancy, and the disproportionate effects of the pandemic on vulnerable populations. Beyond his work at 2 safety net hospitals in California, he returned to his hometown to help in the ICU with the catastrophic surge of COVID-19 cases during the first wave of the pandemic in 2020. He has also served on the Biden-Harris COVID-19 Advisory Board and is an advisor to the Congressional Hispanic Caucus. He was named the American College of Emergency Physicians Humanitarian of the Year for California in 2021. So as you can see, there's many accomplishments and ways that he has been involved in access to healthcare. And in the case of today's talk, focusing on Latinx immigrants. So with that, we welcome you, Dr. Rodriguez.
Thank you so much for the kind introduction. I am gonna try and share my screen. Okay. So thanks for the kind introduction. I'm really excited to be here. This topic is means a lot to me personally, and a lot to obviously the populations that you serve and that we serve. And my talk is going to be Latino. I use the word Latino, but anyway, Latino immigrant populations in the emergency department. And let's see. In terms of disclosures, this is fun. My research has been funded in part by a grant from the University of California Institute for Mexico and the United States. It's also known as UC-Mexis. Are you able to hear me? Yeah, okay. In terms of other disclosures, I, as mentioned, served on the Biden-Harris COVID advisory team. And in event. So the emergency department truly serves as the safety net of the safety net. There are approximately 160 million visits to emergency departments across the country in 2019. And, emergency departments don't only provide emergency care, they truly provide other types of care. I would say at least half of what we see in the emergency department is not truly emergency care, but it's care that for individuals who really have no other place to go. At least a fifth of the US population's only healthcare access occurs through the emergency departments. And this is, there are high percentages of Latinos and African Americans whose primary healthcare occurs through there, as well as certain groups like immigrants and homeless persons and uninsured people who derive nearly all of their healthcare through the emergency department. They can't simply walk into a random clinic and ask for care. So they turn to the emergency department for a large majority of their healthcare needs. This thing is not advancing that well. Okay. The ED, as such, the emergency department also serves as sort of the canary in the coal mine for underserved populations, especially immigrants. And when I say a canary in the coal mine for problems, we see problems in terms of their healthcare and other problems in their overall safety at an earlier point in time, because they really often have no other place to go. We serve as their primary healthcare access point. We try to address a lot of their social determinants of health. And some of my research has delved into these issues. And so these are some of the studies that we've done. I have set up a couple of networks with through emergency department networks of research, mostly in California, but also involving Texas, border cities in Texas, and a little bit on the East Coast and Midwest. And the issues that we've looked at have been fear of discovery and deportation as a barrier to access in the emergency department, the impact of former President Trump's rhetoric on immigrant populations, the impact of rhetoric on reporting of crimes by immigrant populations. We've also looked at misconceptions of domestic violence reporting in immigrant populations. And then my most recent work has looked at Latino immigrants' COVID vaccination status and how to get them the vaccine. So this is a lot to talk about. I'm going to focus on two of these studies. The impact of former President Trump's rhetoric and the COVID vaccine status. All right, so this is a study that we published in PLOS One. I believe it's the study that Dr. Diaz-Strong was referencing. We did this study at 3 hospitals in California. We did it at Zuckerberg San Francisco General Hospital, which is obviously in San Francisco, Highland Hospital, which is in Oakland, California, and All of You Medical Center, which is down south in Sylmar, California, north of LA. And the background behind this study is that there are approximately there are at least 8 million undocumented Latino immigrants in the U.S. in 2016 was that estimate. And I'm going to use the acronym UDLI throughout this talk. And emergency departments serve as their primary healthcare access point for many of these immigrant populations. In 2013, we did a study, really kind of the first study to look at this. But we did a study in emergency departments that found that in which we demonstrated that fear of discovery and deportation deters Latino immigrants from coming to the emergency department, even when they need true emergency care. That is a big fear. They feared that when presenting to the emergency department, somebody might report them, or somebody might, discover their undocumented status and report them. It is not the case. We don't do that, but there was a substantial portion of the population, Latino immigrant population, that believed that. And then leading up to the study, this study of political rhetoric, that we all recognize that there's been a changing political climate over the past, I would say, 6 to 7 years. I want to make it clear that I'm not making this lecture or this study and this talk is not all about a single person, a single person's rhetoric. It just, this rhetoric has been building, but it is clear that former President Trump made deportation of what he called illegal immigrants, particularly those from Latin America, a cornerstone of his campaign. And although the effects of these statements on, attitudes of U.S. citizens, on those that vote, were really well documented by traditional news media and other types of surveys, there was really very little known about what impact that rhetoric had on immigrants themselves. They were not really, it's hard to conduct research on that population. They don't typically respond to internet surveys and things like that. So we wanted to look at this issue, and we wanted to specifically look at this issue about how that rhetoric impacted safety concerns, anxiety, and healthcare access in undocumented Latino immigrants. So the objective of our study was to assess the impact of former President Trump's statements about immigrants on immigrants, especially on Latino undocumented immigrants, and Latino citizens on it. We wanted to look at the effect of those statements on their perceptions of safety and on their presentations for emergency healthcare. So we conducted this study after he was elected. We conducted it from June 2017 to December of 2018. And this was a prospective cohort survey study at 3 county hospitals in California. Again, here in San Francisco, Oakland, and in Silmar, California. And at these emergency departments, about 45% of visits are by self-declared. The visits are people who declare themselves as being Latino. And these were anonymous surveys. We conducted them in private rooms, in English and Spanish. And we categorized participants into 3 groups: the undocumented Latino immigrant group, the Latino citizen group, and another control group of non-Latino U.S. citizens. Further inclusions, this was only for adults. We excluded people that were basically, too sick to participate in a survey. It wasn't like we wanted to, we did not want to like interfere with patient care. And also like we could not interview people who were intoxicated, who had altered mental status, or who were incarcerated. And so we sought to enroll similar numbers of all three groups. And our primary outcomes in this research were the proportions in each of those three groups who had heard anti-immigrant statements from the president, who felt that the statements affected their feelings of safety living in the US, and who felt that those statements by the president made them afraid to come to the emergency department for care. And we did use standard statistical methods. We calculated odds ratios and adjusted odds ratios using logistic regression to see which factors were independently associated with these three outcomes. We also calculated 95% confidence intervals around point estimates for each of our primary outcomes. So we had a very good response rate of 1,684 patients approached. About 79.4% of them agreed to participate. So, a substantial majority have agreed, over three quarters agreed to participate. These were the percentages of the groups. We, again, intentionally tried to enroll a third in each group. These are the demographics of the patients in the three groups. They were in the in terms of like differences, the undocumented Latino immigrant group was the higher percentage of females in that group. Their ages, they were a bit younger. This is this column right here. They, of course, 97% of them spoke Spanish as their primary language, with few of them having English proficiency. Surprisingly, a fair number had some health insurance, but did not have, they had lower levels of primary care. And so in terms of our main results, basically nearly everyone in all three groups had heard anti-immigrant statements by the president. 95% of undocumented Latino immigrants, 94% of Latino citizens, and 85% of non-Latino citizens had heard anti-immigrant statements by the president. Most of the population in all three of these groups thought that these measures were being enacted now, that the threats that former President Trump had made were being enacted now or would be enacted in the future. Most undocumented Latino immigrants and half of Latino citizens felt that these statements made them feel unsafe living in the United States. So 75% of undocumented Latino immigrants and over 50% of Latino citizens felt that these statements contributed to their anxiety about feeling safe in the United States. Approximately a quarter of Latino immigrants said that these statements made them afraid to come to the emergency department, versus much lower numbers in the other two groups, 4% in the Latino group and 3.5% in the non-Latino group. And 55% of the undocumented Latino immigrants stated that, who had some fear, stated that it caused them to delay to come to the emergency department. So they delayed on average about 2 to 3 days. In terms of our adjusted odds ratios for the outcomes, again, the two outcomes were feeling unsafe in living in the US because of political rhetoric, and being afraid to come to the emergency department because of political rhetoric. The odds ratios, the ones that were significant, were that females identifying as Latino, being undocumented, and believing that that the anti-immigrant statements are currently being enacted, made them those had significantly higher odds ratios with those characteristics. In terms of being afraid to come to the emergency department because of statements, undocumented immigrants, and believing that these statements are being enacted, had significantly higher odds ratios. Please stop me, by the way, anybody, and ask questions. If somebody can monitor the chat, please, and feel free to interrupt me. And this is a graphic of representation of what I just presented. And in here, you see the question for this question. The question was, have the statements made by the president and made you feel worried or unsafe living in the US? And as you can see here, the red group is the undocumented Latino immigrants. Purple is the Latino citizens. And as you can see here, this group had significantly, fully over a third of them, said that it impacted them a lot. And another 25% of them, it said that it impacted them in a moderate way. So there are a number of limitations from our research. This is all three of the cities that we conducted this research are sanctuary cities. And we only surveyed people who actually came to the emergency department. Both of these limitations, however, would make it more likely for us to underestimate the true impact. I would guess we did not, we were unable we tried to get this study going in a couple of other states, but there was, we tried to do it in Arizona and Texas, but there was a lot of pushback from, basically pushback to try and accomplish this study at the specific emergency departments where we tried. But so these are, sorry about that, that's my dog. These are sanctuary cities, and so I would guess that the impact in other cities that are not sanctuary cities would be much higher. The impact of that rhetoric. And I've seen firsthand. I'm from Brownsville, Texas, on the border, and I've seen firsthand that there's a much greater fear. The other limitations are that we only looked at Latino immigrants. We did not look at other immigrant populations. There is probably an effect of social desirability. In other words, when you're asking these questions, we tried to use neutral tones and be as neutral as we could. But there is a social desirability for them to respond in. They thought we wanted them to respond that way. And finally, it is a very emotionally charged topic. I can recall conducting a few of the surveys when, and just seeing the participants, start to cry. It's a difficult topic. So the conclusions of that study were that the vast majority of undocumented Latino immigrants had heard anti-immigrant statements from the former president, which made them feel unsafe living in the U.S. and afraid to access emergency care. The former president's statements also had significant impact on Latino citizens in terms of personal safety, a lot of whom have family members who are undocumented. And this political rhetoric, bottom line is that it has induced safety concerns in Latino populations and created an additional barrier to healthcare access. I have one slide on a similar study that we did. And this was, and after this slide, I'll pause for any questions before I go into the next part. We did a similar study a couple of years later. And what we were trying to find out in this study was similar study, same three sites, same inclusion and exclusion criteria, same three groups: Latino immigrant population, Latino citizens, and control group of non-Latino citizens. And we were trying to find out about whether there was a fear of reporting crimes and in Latino immigrant populations. And we published this study in Annals of Emergency Medicine. I can send the link later on. But what we found was that a third of Latino immigrants knew of someone who was a victim of crime. Their primary reason for not reporting crimes was, again, fear of discovery and deportation. And we also gauged the impact of political rhetoric. And we found that over half of them felt that political rhetoric made them afraid to report crimes. So I wanted to pause there before I launched into kind of the second portion of this, in which we're going to talk about the COVID pandemic and its effect on Latino populations.
If anyone has any questions, either use the chat or if you want to use the raised hand function. But I'll pose a question here. Obviously you're looking at the Trump administration and the political rhetoric of that period. But as you mentioned, it's not necessarily about only one person, although it was very heightened in terms of the rhetoric at the time. But I'm curious if you either think that there would be a change or have maybe seen a change in some way with the Biden administration.
That's a tremendous question. And we are planning to repeat the study. But offhand, anecdotally, there's a relief, to be honest. I mean, just is not a fear was fear in my view, and according to our research, fear of like deportation and fear of coming to the emergency department was supercharged during that time period. I don't see as much of that fear now, although it still exists, and it's always going to exist. It exists, and it existed in that first study that we did in 2012, 2013. I'm not saying that, again, I'm not trying to attribute everything to a single person. It's a pervasive societal problem. Yeah.
And we have a question in the chat, sort of getting to the implications. So the question is, are there any of these hospitals using the findings to improve patients' trust in seeking care when needed and increasing patient education, outreach, and support among this population?
Yeah, I mean, we ourselves, our emergency departments, from this research and from other research, have instituted very robust programs of informing people of their rights, everybody's rights in the emergency department, and informing them of their rights to privacy, and that we don't report these matters, that we don't report. And really it's so we started a number of programs that that when people present, we present them this sheet of paper and discuss that they have rights. Now, it is in fact, so emergency department, I'm not aware of any emergency department in the US that reports people to INS. But I'm sure you are aware that in Florida, they have recently passed legislation, or I believe Governor DeSantis signed a bill saying that hospitals now have to ask people about their immigration status, and I think it's a slippery slope. I think that they are gonna start reporting people. So it is an active landscape, and that is that act of having to put emergency personnel in the position of discovery and deportation it's gonna have a tremendous chilling effect. It's gonna be horrible. I don't know anybody who in the medical field who supports it. But it sounds like it's becoming law there.
We have a hand up, Christina, and then maybe we'll take this as the last question so you can finish with the COVID information, but go ahead, Christina.
Hi, I had a question surrounding the involvement of policy and legislation that you considered along with the rhetoric that you were studying, specifically the public charge ruling and the changes to that. Was that involved in your research, and did that influence how you went about the surveys and everything?
Yeah, that's a great question. We certainly considered that that was a part of our reasons, and certainly part of our discussion in the survey, in development of the survey instrument itself and are in the paper itself. We do discuss, the public charge issue. We did not, however, study that. We were thinking of adding a question about that, but there's always a balance when you're doing these types of studies, especially when you're doing them in an emergency department setting. We decided ultimately, we were going to add a question about, have you heard of, this public charge thing? And we just thought that it would create too much confusion. And we also, definitely did not want to introduce more fear. So that is an important topic. We thought about, specifically trying to address that question, but we held off.
Thank you.
For those reasons. All right, so I'm going to talk a bit about another important topic, which is the COVID pandemic, which, obviously a generational occurrence. But I want to talk about, taking research into action and trying to help these populations, underserved populations, by basically action points. And we're all aware that the COVID pandemic had a tragically disproportionate effects on Latino populations, and African-American populations, and Native Americans as well. And some of those reasons are multi-generational housing. A lot of Latinos are essential workers that could not work from home. Their healthcare access issues. During the pandemic, in the first year of the pandemic, it was all about Latinos in the pandemic in the Bay, in San Francisco. So San Francisco's population is 15% Latino. 75% of cases were in Latinos, and over 60% of deaths were in Latinos. It's also a big problem throughout the border. Border states and Latino communities were hit really, really hard. I'm from Brownsville, Texas, which is right on the border. And I volunteered down there during that first summer in their emergency department and intensive care. I do both emergency and intensive care, and a bit, a stark contrast between the two cities. San Francisco's population is about 900,000 more or less. Brownsville and the surrounding area is about 400,000. It's about 88% Latino there and 15% Latino in San Francisco. This is where the big difference is. It's the median income in San Francisco at that time in 2020 was about 140,000. Median income in Brownsville was about 10. All of that translated to disparities on the ground. There were, when I was working in the Bay Area, I would be in the ER or the ICU, and I'd have maybe 20 to 30 COVID patients, and in the ICU, there would be about maybe 5 at most COVID patients. And I was working with a team of a big team of, at least 5 physicians, and we could, in unlimited consultations, and we could provide meticulous care, really detailed care for these patients. When I went to Brownsville, it's an under-resourced place, and we had at least 5 or 6 times the number of COVID patients and 10 times the number of patients in the ICU, and there were just 2 of us. So we were each operating solo. We ran out of medications. We ran out of ventilators. We ran out of really kind of standard things that you need to take care of critically ill patients. And so all of that translates to disparities in mortality. And so by August of that first year, and this is, the first year of the pandemic was just, it was brutal, and it completely different than once we got the vaccine, and the vaccine really changed everything. But in that first summer, there were 700 deaths in the Brownsville area, as compared to 70 deaths in San Francisco. So half the population, 10 times the number of deaths. It became a big deal for me. I became sort of active in Congress. I served on the Biden COVID advisory team, started research on that topic, and want to convey the message that you can do things in the emergency department and elsewhere to improve public health. And so our target, or my target, and my team's target was COVID vaccines. Initially, there were great disparities in vaccine rates between Latinos and non-Latinos. So there was, that was contributing to ongoing mortality. So what my team did was we applied for a grant and started to try and look at delivery of vaccines and vaccine messaging through the emergency department. Because remember, the only place that Latino immigrants are going to get some aspects of healthcare is through the emergency department. They can't, at least at that time, and I would say even through now, it's not like they can just walk into a Walgreens and say, hey, I want a COVID vaccine. They can't, they also can't really, they don't typically go online and, set up a vaccine appointment. There are a lot of barriers to that mechanism. So our thought was to do it through the emergency department. And so we did a randomized control trial of vaccine messaging in emergency departments. We published this in JAMA just a few months ago, JAMA IM. And we did this across the country in San Francisco, Washington, University of Washington, Duke, and Thomas Jefferson in Pennsylvania. And what we did was a cluster randomized control trial of this vaccine messaging. This was from December of 2021 to June of 2022, of adult ED patients who are not critically ill. They had to be English or Spanish speaking. They had not been previously vaccinated. And we developed videos and with basically 4-minute videos in English, Spanish. This is in 5 types of videos, 5 versions. We had a version where the 2 doctors were Latino, speaking in English, two doctors were Latino speaking in Spanish, a version where the doctors were African American, a mixed race group of physicians, and then a white non-Latino version. And so our outcomes were vaccine acceptance and receipt of a COVID vaccine within 30 days. So they're randomized to either getting this messaging or not. And what we found was that we had significantly greater vaccine acceptance, 27% versus 11%, and uptake 21% versus 8%, and much higher effect sizes in those who are Latino and those who lack primary care. And so the conclusions of our research were that these messaging platforms in the emergency department work, basically, and that there are higher effect sizes in Latinos and people who did not have primary care, and if implemented nationally could lead to greater vaccine delivery. So I wanted to finish, with that positive note that you can do things, you can accomplish things with in this population.
Wow, thank you so much for that information. I was, it's like, this about COVID, but it was still just shocking to see those numbers that you put and that you shared with us. So thank you for sharing your experiences. I'll open it up to questions. Again, raise your hand or put your question in the chat. I'm thinking about, the last study that you discussed about COVID. So I'm wondering again, if you have a sense of what the continued hesitancy was for those who maybe didn't take the COVID vaccine.
Yeah, so that's a great question. So remember the dates that we did that study were basically a full year after the vaccine, almost a full year after the vaccine was available. We started the study in December of 21. The vaccine really kind of became available in more or less January, February of that year. And so, we were looking at a highly vaccine hesitant group. We did, I didn't mention this, but we did published another study before developing the videos and messaging platforms, the flyers and the scripted messaging. We conducted in-depth interviews of vaccine hesitant patients, which interviewed about 64 emergency department patients who were vaccine hesitant. We got their views on, we got the reasons why they were hesitant. And so there were a number of reasons. A lot of them were, felt like the vaccine was too new. Some of them, there was a lot of conspiracy theories out there that, people still thought that it was, a government plan, government plot, that they had, that the vaccines even, and I'm not making light of this, but some people believe the vaccines were tracking devices. And so there was a broad group of concerns. And so we, in the videos and in the other messaging, we addressed all of those. We tried to address all of those concerns.
Thank you.
I can send you the link to the other paper that describes their reasons.
That would be great. Thank you.
Yeah.
Any questions from participants here? I always have many, so, but before I ask my next one, I'll open it up. All right, so let me ask this question. We're the Coalition for Immigrant Mental Health. So we're always thinking about the mental health implications. And so I'm wondering, just in your practice and your research, to what extent do you see the overlap between kind of like their physical healthcare needs, the mental health care, and is there a way that the emergency departments also are addressing mental health concerns?
That is a great question. I'm a firm believer that mental health it should be a priority. It affects everything. It affects every aspect of physical health and the problems that we see. And so we try to address that. There's a mental health, as you know, a mental health crisis in the U.S. and especially in emergency departments. From substance abuse to to just anxiety, and it's just a huge portion of what we see. I mean, I would say that, like, in the emergency department and in the ICU, that nearly all presentations have a psychiatric or psychological component, a mental health type component. And we're just like, but our colleagues are overrun. They just, just not enough people to provide care for them. And so we have a PES right next door to us, a separate psychiatric emergency department right next to us. And, they're like my best friends. And so, like, that's just a huge topic. And I think that that does not get enough attention and does not get the support that it needs to be addressed, especially during the pandemic, and especially with our overdose rate has skyrocketed. I mean, yeah.
Well, I'm cognizant of the time. It's 1 o'clock. So I just want to, again, thank you, Dr. Rodriguez, for sharing your work. It's really impactful. It shows us what these policies and beyond policies, just even the talk, right, has a real impact. It's not just words. And then also that there can be some things that can be done, like the COVID vaccine intervention. So we really appreciate you. Thank you very much. We hope, maybe to have you again in the future and to continue to learning from your work. Thank you.
Thanks for inviting me. I put my email here in the chat. I'm happy to hear from any of you who would like to continue to discuss these important issues, and as well as collaborate. And so again, it would be I really enjoyed this, and thanks for having me.
Thank you very much. Thanks, everybody. And do you want to say anything about completing the survey?
Yes, sorry, I just included the link to the survey in the chat box. I will follow up next week also with an email with as many resources as Dr. Rodriguez has shared. and other things that we have, and also another push for you to complete the surveys. These surveys inform our future decisions regarding what kinds of convenings to have, what to focus on, potential speakers to invite. So please complete our surveys today or sometime over the next week. Have a good weekend, and thank you so much for joining us.
Thanks all.
Bye.
Bye.